We come to the end of the day, and after Dr. Pahlajani talked about strain, I hope you are not strained. And if you are, we'll make our last spotters very, very light. So be relaxed and comfortable, and we'll show you some interesting ECGs and some spotters, which many times are given to you in the examination. And I will start with a very simple one. And first one, this is a 78 years female, sudden palpitations, and I would like you to have a look at the EKG. Anybody wants to take a chance and say what it is? Very quick, very fast. Tell me. Can't hear. What is it?
Atrial fibrillation, sir.
It's say it loud. Anybody, one person to stand up and say.
It's 12 lead normal standardized ECG showing a neurocomplex tachycardia, irregular in rhythm, and the precordial lead we can see the R waves are okay, but limb lead showing the low limb voltage. And the age is 75 years, likely might be any atrial enlargement causing the atrial fibrillation. We might be might be a RCM.
So therefore, in other words, what you're saying is an atrial fibrillation with a fast ventricular response.
Yes.
Now, therefore, I will ask you, what should your treatment options? Should we give IV Cardaron, IV digoxin, IV diltiazem?
I would like to know the hemodynamic status of that patient.
I think patient was hemodynamically quite stable. And the last one is to immediately perform a DC cardioversion. What will you do?
Rate control will be the ideal one.
Rate control will be ideal. Anybody else has got any difference of opinion? Will you like to revert these patients to normal sinus rhythm by giving IV Cardaron?
We need to see the time. We need to rule out the clot. Then we can go ahead with the cardioversion if it is.
Will you do a DC cardioversion on this patient?
Without knowing the clot, it's very difficult.
Who's speaking? Can you stand up? Somebody who's speaking? I can hear only from the speaker. But who's the one who's... Oh yeah, last one. Yeah. Will you do a cardioversion on this patient?
No sir, directly we can't proceed. We have to see for the any LA clot is there and what duration AF it is.
Yeah, I think it's very good answer. First of all, when you see an atrial fibrillation with a fast ventricular response like this, couple of things you have to know. Number one is a hemodynamic status. If the hemodynamic status is compromised, then I think of course that time you can take a chance to do a cardioversion. However, if the patient is hemodynamically stable, first time you've seen a patient with atrial fibrillation, do not do cardioversion. The reason being, you don't know, patient might have been getting atrial fibrillation paroxysmally, and there may be a clot inside, and you may shoot a clot if you try to do a cardioversion. So your choice should be to rate control either with IV diltiazem, or you can even give IV Cardaron, which may do a pharmacologic cardioversion. This is another patient, male, 56 years, palpitations on and off, no history of chest pain, resting ECG and echo normal. Can anybody tell me what exactly it is? Okay, I'll give you a clue. First, have a look at the ECG, then I will give you a clue. Could it be a ventricular tachycardia? Could it be an SVT with aberrant conduction with right bundle branch block and a left axis deviation? Was it an atrial fibrillation with aberrancy? Was it a fascicular tachycardia? Or was it an atrial flutter with aberrancy? I've given you some 5 options, so I'll go back now. Look at it very carefully and let me know what exactly you think.
Fascicular VT.
First of all, is it ventricular tachycardia?
Yes.
Why do you say ventricular
There
tachycardia?
is normal capture beat.
Is it the same person speaking?
Sir, left posterior fascicular VT.
Yes. Why do you say it's a left posterior?
Sir, it's QRS morphology is between 100 to 120, less than 120 milliseconds. with
Okay,
an
why I will
RBD.
ask you one question. Why this is not a supraventricular tachycardia with aberrancy? Is there anything pointer in this ECG which says no, it is not a supraventricular tachycardia? Can you look at all the leads, especially lead L2? Is there some pointer there?
Yes, sir, the capture beat is there, sir.
What do you find there?
Beat 2, sir. There is a capture beat.
There is a sinus beat there.
Sinus beat.
Once you see something like aberrant ventricular, when you see a white QRS complex tachycardia, if you see a fusion beat or if you see a sinus captures, it indicates that the patient has got a ventricular tachycardia. So you are absolutely right. The location seems to be, you are again right, it is a left posterior fascicular tachycardia because there is a left axis deviation and there is a right bundle branch block. I think it's a very highly diagnostic of the patient with a left posterior fascicular tachycardia. Now what will be your, so our diagnosis is fascicular tachycardia. Now what is your treatment for this? Amiodarone, sotalol, verapamil, lidocaine, DC shock.
Verapamil.
Verapamil. This is the only white QRS complex ventricular tachycardia which responds to the verapamil. It does not respond to anything else. You can try something else, but it's very specific to give a verapamil to control this tachycardia. Okay, anybody to take a guess on this? What is this tracing supposed to be?
It is CV waves actually.
Huh?
CV waves.
It's said, let me tell you, below is the aortic tracing. What do you find?
IABP 1:1 diastolic augmentation.
Pardon? But where is the signal for the IABP? Where is an augmentation signal? So what do you see? One is a large complex pressure tracing. Another one is a smaller tracing. So what is this? Every alternate beat.
Pulses alterns.
What is that? What is that? Say it loudly. Pulses? Alternance. Yes. It indicates a severe left ventricular dysfunction. Really it indicates a real left ventricular dysfunction. Patient is about to die. Now this one I think Dr. Rishi Sethi has already discussed on the Valsalva maneuver. So I don't want to go into this. And okay, what is this?
Torsades.
Torsad. Absolutely right. You can see an undulating QRS complexes of different, they're actually moving around one axis, up and down. This is Torsadi pontes. And what is the treatment for this?
Magnesium. Magnesium.
Magnesium. So can you give a shock to these patients?
No.
Actually, if you see this ECG, a DC shock has been given to this patient and patient has converted to normal sinus rhythm. So DC shock in a very desperate situation can be given. Of course, the choice of treatment is IV magnesium sulfate in these patients to be given 2 grams intravenously. Okay, now I will ask you one question. You see this gentleman and he has got a posture like that of an Englishman. Anybody can take a guess?
William Harvey.
Okay, I'll give you the 4 options. William Osler, William Harvey, William Heberden, and William Shakespeare.
William Harvey.
William Harvey. Anybody else? Can he be a William Shakespeare? Any other guess? Now 2 guesses are gone. William Osler. He is a guy whose description we even recite today, and the maximum money that we make in our clinic is because of this man's description of angina. What was his name? Huh? Aberdeen. This is William Aberdeen, an English physician who described angina in somewhere about a century back. Okay, now here's a 24 years medical exam patient who has come, person, not patient, who has come for medical examination for pilot job. Will you certify him? Will you certify him for the... Please. Will you certify, first of all, my question, will you certify him for the pilot's job? No. Yes or no? No. Why not? Why not?
Sudden cardiac death.
Huh?
He has a tendency of having sudden cardiac death.
So what is this called as? Why he will have sudden cardiac death? Brugada syndrome. What are the features of Brugada syndrome which you can describe on this ECG?
So there is coving of the ST segment.
Yeah, if you look at the V1 and many times V2, you find something like an RSR pattern, and the terminal part is slightly ST elevation. This is very typical of Brugada syndrome type 1. And these patients are known to suffer from sudden cardiac death due to ventricular fibrillation. What is the treatment for these patients? ICD. Okay. Now, here's a patient, just few days back I left, and I was referred this patient by our gastroenterology colleague. She's a 35 years female, and she actually presented to our emergency medical services, breathlessness, ascites, liver 4 fingers, was referred from the EMS thinking this to be a cirrhosis of liver, or referred to the gastroenterologist, who did not know what exactly was happening, did the upper GI endoscopy, did the lower GI lower endoscopy, did not find anything, and then referred the case to us, and the first thing we did was to do an echo, and this is the echo, that's what we did on this patient. And okay, 1 minute. I think this is not connected to the, no, it is not. Okay. All right, what do you find? I think allegation will laugh at us if we don't say what it is. Anybody? RA myxoma. You see a big tumor popping in and out of the tricuspid valve. The right ventricle itself seems to be slightly narrowed or maybe smaller in size, but there's a big mass which is coming up and down. Can this be a clot? Can this be a right atrial clot which is coming up and down? If you see, the mass looks like sessile. It's not sessile. It has got a peduncle. Possibly it's popping up and down. When you see something which is popping up and down, it is very unlikely to be a clot. It's a very rounded shape. It's on the right side, and it must have obstructed the tricuspid valve. That's why the patient must have developed ascites and liver enlargement. The people thought this was probably some gastrointestinal problem, and then of course this patient, I think, is being operated today as an emergency procedure to remove this right atrial myxoma. So this is very classical of the right atrial myxoma. Okay, here's a patient who came with flu-like symptoms, and 32 years female. See the ECG, what do you think it is? Pardon? Pericarditis, correct. What is the other differential you would like to offer on this?
Benign early repolarization.
Early repolarization pattern. Don't diagnose this as an infarction, because if you see the ST elevations have got a concavity up. Once you see a concavity up, it's more likely to be either an early repolarization pattern or acute or pericarditis. And this patient had a very short history, had a flu-like symptoms. Therefore, I think we made a diagnosis of the pericarditis in this patient. Okay. Anybody can take a guess on this physician?
First angioplasty.
Again, because of the description what this physician gave, we all are making millions of rupees and millions of dollars. Just give a small
Rossman.
hint. Is a physician
Rossman.
from Chicago.
Hello.
Anybody has seen this picture?
Rossman.
Who described the anterior wall infarction with an occlusion of the LAD at the postmortem specimen and said the only hope led for this man to have a recanalization of the LAD? Anybody? Dr. James Herrick, physician from Chicago, who attended on an autopsy of a patient who died of anterior wall infarction. The autopsy showed a clot in the LAD, and he made a comment when he wrote this description in the American Heart Journal that the only hope lay for this gentleman was to have his LAD opened up. So I think that probably was the earliest prophecy made for the patient's treatment of acute infarction, either with thrombolytic treatment or with angioplasty. Okay, anybody can take a guess on this X-ray? Can you describe, anybody can describe the X-ray? Can read an X-ray? Come on, it's very simple to read X-ray. When you see a photograph, how do you describe? Looks like a beautiful woman, has got good hair.
With decreased pulmonary blood flow.
Please stand up and say.
It's a central like heart, mesocardia.
No, who's there? Who's speaking? Okay, again at the end. Why don't you come in front? Huh? Yeah, tell me.
So it's looking like a mesocardic heart, and the blood flow is very much decreased, oligemic lung. And coming to the situs lung, means liver is on the right side. Means atrial status I can't make it out, means it's a which side that means bronchus. But
So in other words, it's an AP chest, right?
yes, sir.
It's an anterior-posterior X-ray of the chest with the stomach bubble on the left side, liver shadow on the
Right side.
right side. Heart is well centralized. This is how you should read an X-ray. And of course, you can't see the trachea well, so you don't know whether the trachea is shifted or not. But obviously, it looks like it's a well centralized place. Then you go to the lung markings. What do you find the lung markings?
Decrease, sir.
Decrease. They look like oligemic lung markings. Now, what do you see in the cardiac shadow? How is the apex like?
It's in center like mesocardia.
What does the apex look like? The apex seems to be slightly lifted up, correct? And the lung fields are oligemic. So what is your spot diagnosis on this X-ray?
Top.
Could be a tetralogy. Any differential diagnosis on tetralogy of fellow differential diagnosis? Oligemic lung fields? Double outlet right ventricle? Transposition of great vessels with severe pulmonary stenosis, but there usually the heart size is slightly larger, right? So this looks like a tetralogy physiology, and maybe it could be a tetralogy of fellow. I think that's what you should describe your X-ray. Okay, now I'll go to this. This is actually this my very favorite angiogram which I used to do. They showed in the past, and I've done this when the child was very small baby, about a month old. And this was a catheter. Can somebody read this? This is an angiogram. Let me see. Yeah, at the end. Yeah.
It's an RV angiogram. We could see the catheter placed in IVC through RA to RV, and the injection has been done in RV.
No. Tell me, this is a catheter. You are saying is put from the IVC. I'm tracing it up to RA, and then
to RV.
To RV. Yes. Okay.
Ventricle, and then the injections show there is
Injection is done with a contrast.
Yeah.
And then what is happening?
So RV is filled, and we could also see the dye getting infiltrated into the probably the coronary artery.
Correct. Very good. Yeah.
So it could be a L-kappa, that is anomalous left coronary artery from pulmonary artery.
No. Do you see the pulmonary arteries coming up anywhere? And you see the right atrium being, I'm sorry.
So it could be the RV dependent coronary circulation,
Do you see the pulmonary valve anywhere?
pulmonary atresia with RV
Yes.
dependent coronary
Yeah, correct.
circulation.
So you don't see pulmonary valve, so it is a very classical picture of a pulmonary atresia with what?
RV dependent coronary circulation.
It's a pulmonary atresia with intact ventricular septum, because if there was to be a ventricular septum, you would have seen a part of the left ventricle getting opacified. And these are very typical what you describe. These are right ventricular coronary sinusoids. So these are actually circulations which are going into the coronary arteries from the right ventricle, and they go like a serpent here. And there is a severe tricuspid regurgitation because there is no dye or there is no blood flow going into the pulmonary circulation. Okay, now can somebody describe this? What is this supposed to be? Anybody has seen this in the lab?
So it's a balloon atrial septostomy procedure.
Balloon?
Atrial septostomy.
Yeah, it is a balloon atrial septostomy catheter. Who described it?
Rashkin.
Bill Rashkin. Bill Rashkin was the one who did the first. As a matter of fact, as far as I'm concerned, he was the first interventional cardiologist, because he was one fellow who did the septostomy of the atrial septum as early as in 1960s in a baby who was dying of cyanosis. And what are the indications of performing balloon atrial septostomy? Indications?
TGA with restrictive ASD.
So it could be EJ intact ventricular septum.
Transposition of great vessels is the classical indication to be done. Okay, any other indication you know of?
So HLHS with a restricted.
What is it? What is it?
Hypoplastic left heart syndrome, probably with a restricted PFO.
Correct.
APDC with a
Particularly you saw the patient, we showed you the patient with a tricuspid, either tricuspid atresia or pulmonary atresia with a restricted ASD. If you want to maintain some circulation, decompensate the right side, you can do a balloon atrial septostomy to tide over till the interventional pediatric cardiologist comes and does the, put in a wire, opens up the balloon, with the balloon opens up the pulmonary valve. Okay, now anybody wants to comment upon this X-ray at the top? There is an angiogram also below, but look at the X-ray at the top. Just give a spot diagnosis, very straightforward. Do we have time, Shiv?
TAPVC.
Huh?
TAPVC.
10 minutes more. Just look at the X-ray at the top. We have shown the arrow also.
Top with absent pulmonary wall.
What is it?
Top with absent pulmonary wall.
Top with absent pulmonary wall. X-ray, X-ray.
It is right aortic arch.
What does the X-ray look like?
Figure of 8.
What does it look like? Snowman.
Snowman. Figure of 8.
What is a snowman appearance classical for?
Supracardiac TAP.
Yeah, correct. Total anomalous pulmonary venous return of the what type?
Supracardiac.
Yeah. Okay. So that's the classical example. As a matter of fact, you can see at the bottom there's an angiogram also which shows the complete opacification of the chambers which are opacified after the injection done, and which shows that these shadows correspond to the anomalous veins draining into the right atrium. Okay. Now let's see the next picture. This picture is taken from simultaneously from the right ventricle and the left ventricle. And what do you find? What's your diagnosis when you see this kind of tracing, ventricular tracings, right ventricle and left ventricle tracings? This is a spot diagnosis. When you see this, what does it look? Both of them are more or less in the height same. Number one. Number two, the top of the tracings looks flat, same. Right ventricular tracing and the left ventricular tracings look same. So this looks like what? When you see this like this? Huh? Huh? Constrictive pericarditis. This is a classical when you see of tetralogy of Fallot, because the ventricles, pressures in both the ventricles are absolutely identical. One could say, okay, the right ventricular pressures in the right could be same as the left ventricle in, say, for example, in pulmonic stenosis. But the pattern of the right ventricular tracing will be like straight and then down. Here you can see the top is absolutely same. So when you see something like this, as a matter of fact, both the chambers are acting as in the similar fashion, generating the similar type of pressure. So therefore you find equal pressure with the equal pattern, similar pattern in tetralogy of Fallot. Okay. Now, anybody giving me a diagnosis? I think this possibly now we already discussed. What is this? Is it a supraventricular tachycardia aberrancy? Is it a ventricular tachycardia? What is it? Somebody gave a just now an explanation. Is it VTAC or is it SVT with aberrancy? Huh? Again VTAC, because now here you can see it's very classical. You can see here fusion beats. Once you see fusion beats and a sinus captures like this, it is nothing but ventricular tachycardia. It can't be anything else except ventricular tachycardia. I think we already discussed this. And okay, I'll ask you the last question. This pertains to our own country, and of course unstable angina has been described all over the world by different speakers and different workers. But in the world, the first description of acute coronary syndrome, unstable angina, pre-infarction angina, whatever you want to call, came from India and is recorded. I want to ask you, who amongst was the earliest to describe the syndrome of unstable angina? Was it Dr. Sujoy Roy from Delhi, KG Nair from Mumbai, Rustam Jal Vakil from Mumbai, or Dr. George Cherian from Vellore? Anybody give a guess? Correct. Rustam Jal Vakil from Mumbai described this, and as a matter of fact, his paper is there in the circulation in 1961, where he showed that he described his patients. As a matter of fact, all his patients from his own clinic. They were not from any other institution. And he described their pattern over few months earlier, how they behave. And he published his paper. And today, even today, I think his description is valid. And I think we'll go to the last picture. And can anybody describe this ECG? 75 years male, palpitations. Atrial fibrillation, atrial flutter. What is it?
MAT,
SVT?
multifocal atrial tachycardia.
Multifocal atrial tachycardia. Very right. Actually, you can see here in this patient, there are various places where you see P waves, and the configuration of the P waves keeps on changing. And this is very typical of the multifocal atrial tachycardia. Usually occurs in the patients who have got a COPD, and the treatment is very simple. You have to give them, control their rate either with verapamil or digoxin and treat their COPD. I think we can end here, Shiv. Huh? We can end here.
Thank you, sir. So with that, we come to the end of the first day session. And before you disperse, and I'm very happy the response by the students is quite encouraging. And we have one long case and two short cases. Before that, there will be two lectures, because I again don't want you people to miss Dr. Ramakrishna from All India Institute, who will be talking on cyanotic heart disease, and Sandeep Bansal on his topic. I forgot his topic. Okay. So, yeah. Then basically after that we'll have a long case and two short cases. Total 19 people have volunteered themselves. So what I would suggest is we will take about, we can't allow all the 7 to be there and then do a combined diagnosis, because then the whole purpose will get defeated, because there unfortunately you will be alone when you go for an exam. Okay, so we'll make it into the groups, but we'll allow only 2 people to go and examine the whole thing and make their diagnosis. But when they are presenting it, we'll keep these 3 groups, okay, so that they can keep answering it whenever the examiner asks. Suppose if the first 2 people are not able to answer it, the other say 6 people or 5 people, whoever it is, they can answer it. So eventually we will have only 2 people who can examine the case, because 10 people examining and discussing and other things will not be an exam pattern. Is that okay, sir? Okay. So in a short while, we'll tell you that who are the people who can go and examine those. So tomorrow morning, actually the presentation long case is at 10 o'clock. So we'll allot you by 9 o'clock so that you get a 1 hour time to examine it, and by 10 o'clock. And similarly, short cases will be given 45 minutes before, and so that by 11 o'clock they can go to the short case presentation. Okay.
Yeah. Check. Yeah. Couple of announcements. Today's dinner is from 8 o'clock to 11 o'clock at the pre-function area of this hall. Tomorrow, all trainees who are at Radisson, please have your breakfast at Radisson, check out and come over with your luggage. All at Trident, please check out and come in for the session. We start at 9:30, not at 10. So please be inside the hall by 9:20. The breakfast timing for tomorrow is 7:30 a.m. to 9:15. I repeat, 7:30 to 9:15. Thank you so much. Good night. Yeah. Yes.